Thank you for joining me in our Strategies of Success WebEx series today. This WebEx is entitled Understanding Reimbursement on the Road to Increased Profitability. My name is Carolyn Parker, and I'll be presenting this information on this topic today. Should you have any questions during the presentation, please feel free to submit them and as you participate, and I'll answer them at the end of the presentation. The information provided in this training module is not intended to be legal or medical advice. It is recommended that participants not rely on this general guide in structuring or analyzing individual transactions, but that professional advice be sought in connection with any such transaction. Nothing herein is the official position of Allegiant Creighton Health. Now within this WebEx, I'm going to be discussing insurance basics regarding reimbursement, compliance programs, benchmarking, and how to monitor reimbursement in the form of claim denials. So first thing we're going to do is we are going to start with reviewing the EOB. So what to look for in the insurance explanation of benefits. Most billers already know this, but I thought it'd be nice to go over the basics in case you have a new employee in your office. First thing you want to look at when you're looking at the EOB is look for the zero amounts as the approved charges, as well as look at the remarks and description field. And in working claim denials, it's important to know that the remittance advice denial codes are, and I put where the list of denial codes can be found right here for you, and this will be offered as a PDF on the MSO website for you. So if you need to go back and review the slides, this will be available. Another thing you want to have your billers do for reimbursement is making sure that the proper adjustments have been made. So once they look at all of these things, they want to figure out what the reasons for non-payment were. Taking the time to make sure that a procedure or a treatment or an office visit was covered prior to the patient coming in will save you time and money. Additional staff may be needed to explain the patient policies to them and determine a financial plan for payment for your patients. So help the patients look for reasons for non-payment, whether it's a deductible or policy exclusion. You're going to have to collect payment directly from the patient. You can be proactive to find out what the deductible coinsurance prior to their visit or treatment and educate them and set up a payment plan. So when they see these on the EOB, it is a good idea for your staff members to contact the patient and counsel them on this. And some patients really don't understand the deductible or their coinsurance or their out-of-pocket max. So staff members really should be savvy in versing this to patients. Looking for errors on the EOB as well. Looking for if the claim was processed in error, then they should be appealing the claim. And then for non-covered services. With non-covered services, it is the patient responsibility. However, if you have a patient that has Medicare, any governmental program, you have to have them sign an ABN prior to this. It's a good idea to verify before you do any type of procedure, lab test within your office or surgery to make sure that it's going to be covered before the patient even comes in. Because if it's a Medicare patient and you don't have them sign an ABN, then they don't have to pay the claim. Information needed when you do actually have your staff members appeal a claim. They're going to need the name of the insured patient, identification number, date of service, the amount of the charge, the amount that was paid, explanation of why it was denied, and of course the insurance company phone number or website. Some insurance companies will have this available on their web too, that you can appeal it online. When you contact the health insurer, you're going to want to locate the following: the fee schedule, the reimbursement methodology, and you should really be keeping track of that. You could see some trends with some of your insurance companies. The name of their claims editing software, if applicable. I know that there's some insurance companies, especially the ones that are self-funded plans within Midland's Choice, that don't really help when it comes to secondary claims. They don't pick up on all the new edits. You can see if there's some trends or problems when it's going from the clearinghouse to the billing company. This will help your billers be aware of these things and know how to adapt to them, and maybe make a little note on that particular insurance company of what some of the setbacks are. Find out what the multiple procedure same-day payment policy is, the bilateral procedure payment policy, and the pre-authorization policy. Different payers have unique appeal processes. Someone in your practice really should be compiling the appeal processes for your major payers onto one reference document available to all staff. Well, the appeal process might include some or all of the following. Submitting a corrected claim. This is really a lot less work than a full appeal. Appealing via the website or via phone call, fax, or letter. But please note that the expense of reworking a denied claim becomes more expensive as you work down the list. In other words, don't send a letter if you can send via their website. If your appeal is not successful, you're going to have to consider the payer's formal appeals process, which can include several levels of appeal and reviews by an appeals committee or board. Before going down this path, you need to confirm with the payer all the appropriate steps and communication channels required by the payer. Also within the appeals process, you're going to contact each health insurer to locate the following. The claim prompt payment policies and penalties. You can also get those from Uninet with the ones that you participate with those. The claim submission policies to include timely filing. The medical review policy, the claim appeal policy, the global period definition, and the health insurer contact information. Having a solid contact in the insurance company themselves is really helpful. Each insurance company should have someone who is dedicated to your region to be able to help you with claims that you can't seem to get paid promptly. Some processes you might want to consider within this, and again, this was just a brief overview according to reimbursement within the billing cycle. You want to prioritize your denials by the shortest deadlines, then by the largest amounts due. We do have the payer deadlines from Uninet. However, not all practices participate in Uninet or all the contracts that they offer. We do have some appeal letter templates that include the patient name and demographics, data service, CPT and ICD-9 codes, and a short, clear explanation of why you're appealing the claim. And again, on the MSO website, I do have some appeal letters available for you. Evaluating and tracking your most common denials and trying to figure out the processes to prevent these denials from occurring. So once you have some of the basics down, big thing with reimbursement is trying to be more proactive than reactive with your claims. So working denials is really important, and some of these steps hopefully will help you, but you really should try to be more proactive with your registration and with other things to make sure that your claims are going out clean the first time. Now we're going to move on to compliance, because that also will affect your reimbursement. And let's face it, no provider really wants to implement and maintain a compliance program in their office. But if nobody bothered, then the estimated $60 billion in Medicare fraud would continue to prosper. The reason why I bring up compliance within this reimbursement WebEx is because compliance is necessary for you to get paid in the future by Medicare in particular. If you think about things with HIPAA, if you're not following HIPAA or OSHA standards, you can get huge penalties to your office. Also, there's the PQRS testing and reporting that you're supposed to be doing right now. If you're not doing PQRS reporting this year, your practice will be penalized in 2015. So we're going to talk about compliance real quick. Specifically what the Office of Inspector General, also known as the OIG, expects you to have. First of all, you need to have a compliance officer. So your office has to appoint a trustworthy person with sufficient authority to influence behavior and organizational practices. The role of the compliance officer, well, they have to draft and administer an effective compliance plan. They have to perform organizational risk assessments, and this step is often missed. Implement and enforce government policies based on standards and guidelines. Communicate with the physicians and staff about compliance issues. Ensure that all staff members have appropriate levels of training. Monitor the coding, billing, and documentation for problem areas. And watch for improper inducements, kickbacks, and potential fraud. So why do they expect you to have a compliance plan? Well, like every other law and regulation, our government imposes medical office compliance programs are intended to better society. An effectively designed compliance plan should be implemented and enforced with the goals of preventing, detecting, and correcting inappropriate potential criminal conduct. Reducing your exposure to liability is another key reason for implementing a compliance program. Making reasonable efforts to avoid and to detect misbehavior is evidence in itself that a practice does not have to intend to commit healthcare fraud, thus may reduce penalties if wrongdoing is found. The design and implementation of any compliance plan will vary from one practice to another. A compliance plan for a high-volume practice will differ from a low-volume practice, and a specialist plan will differ from that of a family practice, whereas a lab will differ from a mobile practice. So in order to be effective, the plan needs to be designed for services and structure of your practice. Establishing an active compliance program will require both time and money, but the alternative could be much more expensive in the long run if you are audited. So in this, you do need to develop a code of conduct and develop standards of the code of conduct for all employees that reflects your practice's core values such as integrity, respect, stewardship, compassion, service excellence, compliance training, and more. So what do you include with your code of conduct? I did list it here. Also within the MSO website, we do have available a compliance plan that you can put together and base off some of these things that you need. Training and education programs. The practice must establish an effective and documented education and training program for all personnel, including an overview of healthcare laws, payer requirements, an overview of the plan itself, and the role each employee has within the plan. On June 10, 2011, the Department of Health and Human Services awarded a $9.2 million contract to create an audit protocol that audit covered entities and business associates' compliance within the privacy and security requirements of Health Insurance Portability and Accountability Act, also known as HIPAA. These audits were expected to continue through last December, but they're still continuing on now, in an effort to find medical entities that fail to comply with HIPAA regulations. Audits will expose non-compliant providers, the potential for heavy fines, and reputation-damaging publicity. So we have actually on the MSO website HIPAA training available under the Training Center. At the end of this presentation, I'll show you how to access this. You're also expected to have a hotline, the creation and maintenance of a process to receive complaints and procedures to protect the anonymity of complainants and the protection from retaliation. The disciplinary process for violations of compliance programs will be administered according to practice protocols, generally oral or written warnings, suspension, or termination, depending upon the seriousness of the violation. Then you have to have a corrective action plan. This is a process for responding to complaints, addressing the identified offenses, and taking corrective action to prevent further similar offenses. And again, I had in here information on compliance because if you aren't compliant, this can affect your reimbursement in the fact that they will come back if you ever get audited. They'll look at every little part of your practice to see if you're compliant in different areas. And then also you want to be compliant within HIPAA standards because billing staff do talk to patients just as much as front desk staff do, and you have to be careful what type of information is given when they're appealing claims. There has been cases cited that if there's like workers' compensation claim, just last year there was a patient that complained that they violated HIPAA in giving information from the doctor's office to the workers' comp claim center, and so that was a really big problem for them. So making sure that you're protected within HIPAA and other regulations with compliance is really crucial. Now we're going to move on to benchmarking. If you kept track of every administrative detail in your practice, you really wouldn't have time Your doctors wouldn't have time to see patients, and you wouldn't have time to monitor your staff. So what you have to do is triage this work to make sure it's effective and efficient. You have to work with your clinical staff and administrative staff to monitor the vitals of your patients, and your front office staff can monitor the vital signs that reveal your practice's financial health. So I have some suggested benchmarking tips that are simply supposed to help your financial discipline and measure your performance systematically. First thing you want to look at is your days and hours worked. Tracking days and hours worked may help you make a sense of a decrease in charges. The cause of decrease will be readily apparent if your physicians in your group have taken vacation in a period in question. If work hours are in line with the norm, then you're going to have to explore other explanation why your charges are down. Speaking of charges, they are a significant variable when benchmarking a practice's financial performance. Many factors can affect charges. For example, they can be impacted by a very high fee schedule. Ancillary services can also have a big impact. Coding skill also varies significantly and can have a measurable effect. Watching the variation in your charges from one month to the next is the best way to identify variables that might be affecting your profitability and take corrective action when appropriate. Seasonality also has an impact you can influence, with charges typically lowest in the summer and highest in the middle of winter. However, billing delays, changes in billing staff, or declines in service volume, for example, can lead to noticeable fluctuation in charges that may need to be addressed. In collections, most practices keep an eye on the amount of money they're collecting each month, but they don't necessarily look at the figure in relation to other metrics. It's more telling to track collections as a percentage of charges. As you do this, keep in mind that most practices, reimbursement follows charges by 2 to 6 weeks depending upon the insurance carrier, whether the contract involves capitation, as well as the time of year. And since collection ratios often drop in January during the deductible season and are recaptured in February or March, a collections to charges ratio between 50 and 80% is typical. Inflated fee schedules will reduce the collection ratio. The important thing is to monitor your ratio monthly to identify significant changes that need to be explained. Potential causes include changes in your payer mix or reimbursement rates, failure to collect copays, and failure to follow up on denied claims. And I actually have a couple of WebExes that focus just on those specific areas that might be able to help your practice that I recorded previously. Now within adjustments made to your charges are another area where you should pay particular attention to variations and consider them symptoms of underlying problems. Embezzlement, changes in billing patterns or payer mix, recurring data entry errors, and other issues can be identified by investigating changes in adjustments. On average, your adjustments percentage is the inverse of your collection ratio, although it will almost never appear to be compared with month to month because adjustments follow charges by 2 to 8 weeks, depending upon your billing cycles and past productivity. You should compare this month's adjustments to charges and collections from last month or the month before instead of the current month's charges and collections. A normal accounts receivable for a full-time physician should average approximately 100% to 120% of monthly charges, with half of this amount being under 30 to 40 days old. Obviously, a full capitated practice would have almost no AR, and a practice that provides lots of obstetrical care has most patients enrolled in PPO plans may have significantly more. A physician returning from a 2-week vacation would be expected to have fewer dollars in AR due to having fewer charges. I've seen practices with a 500% ratio of AR charges and found upon investigation that the vast majority represented accounts from 1 to 5 years old because the staff never adjusted off bad debts. In that situation, the AR metric is not useful. High AR rates can also be a symptom of delayed claim submission, dirty claims, excessive fee schedules, and a host of other issues that require attention. Patient counts. And keeping track of new patient, established patient, and inpatient counts can provide perspective and understanding of other metrics. For example, many practices see a drop in charges and all the downstream statistics upon closing to new patients because the fee for new patient visits is higher than for established patient visits, and new patients tend to consume more tests and ancillary services than returning well-managed patients. The number of your patients who are also hospitalized can significantly impact your monthly financial picture. The average visits per day is a good measure of productivity and efficiency. It's also a good metric upon which to base staff bonuses if you do that within your office. If your practice is sophisticated enough to track and report on physician work RVUs, this number can be a better measure of productivity than charges or patient visits, since it adjusts for acuity. Remember that coding habits have a significant influence. Because it may be impractical to report RVUs more often than monthly, it is not an effective measure on which to base day-to-day behavioral change strategies. Many practices already monitor expenses on a global basis, but expenses really should be tracked by category as well. A common mistake is to use the limited categories of expenses listed on the IRS forms and that CPAs use to report your taxes. A better approach is to use an expanded list of categories called a chart of accounts or general ledger categories that provide you a more detailed cost information into which manage your practice. It's much more easier for a CPA to consolidate a detailed chart of tax for accounts for tax purposes than it is to extract useful information from a too limited one. Net income and physician compensation. When capturing these figures, a common error is not to include the physician's personal benefits, such as health insurance, retirement contributions, travel, entertainment, automobiles, overcompensation for family members, CMEs, club dues, computers and supplies for home use, and cell phones and internet accounts, all of which are compensation to the provider and failing to account for the effects of depreciation, which is a tax adjustment, not just a cash expense, and interest, which a mature practice should rarely be paying. Also be sure the benchmarks that you are set in keeping in the number of hours your physicians work. If they're working 80 hours a week, they're at 160% FTE, and their income and the benchmarks they're comparing it with should be modified to reflect their level of labor. Next, I'm going to go back and address rejected claims. We're going to talk more about how to appeal them and, more importantly, how to be proactive, like I discussed before, to avoid most costly denials. According to the MGMA's findings, the average number of rejected claims for a medical practice is 30%. Only 50% of these claims are ever resubmitted. This can represent a huge sum for physicians who are unaware of how their billing office handles claim submissions. Most physicians leave 24% of their revenue uncollected. If your claim to a benefit under a plan is denied in whole or in part, you, meaning the patient, will be notified in writing the claims administrator for a benefit plan within 90 days of receipt of the claim. It's 180 days if special circumstances apply. If special circumstances require an extension, the patient will be notified prior to the termination of this initial 90-day period. Most claim denials occur from improper registration of the patient's demographics. Asking the patient for their driver's license and current insurance card can deter these errors. The verification of benefits can deter termination errors. A lot of practice management system programs have software internally to catch these, but the best way is to contact the carriers directly, either via phone or on their website. Or there's even some programs within practice management systems that you can run ahead of time. The EOB remark indicates that a payer has received another claim for the same service and the denial reads as duplicate claim or previously paid. However, the claim may not be a true duplicate, and for the following reasons. It could be because the CPT code was performed more than once on the date of service, or by two specialists in the same multi-specialty group, or the payer's computer system doesn't read your modifiers submitted to your claimant adjudication system. For these reasons, staff can't just write off these claims as duplicates because the denial may not be accurate. The staff member needs to review the patient's account to identify the potential reason for the duplicate denial and take action based on that. Consider developing a decision tree tool for staff to refer to when regards to duplicates. Verification of benefits can deter termination errors. A lot of practice management systems have software internally to catch these, but the best way is to contact the carriers. If you happen to find that there's 2 chest x-rays on the same day, then you want to review the process the claim submitted to see if the code was appropriately coded, and if not, they'll correct and resubmit it. Like I said before, with duplicate claims, make sure that your billers are aware that just because it's written off and it says it's a duplicate claim, they really should investigate it and not just write it off. Unfortunately, claims with prior authorizations are denied more often than you might think. There are some common reasons why these denials that you should take into consideration. You can attempt to appeal these denials, but most insurance companies will not reverse their decision. So you're going to know each individual insurance plan requirements for pre-auth and pre-certification process, again being more proactive than reactive. When medical records are requested, send records with a copy of the request within the time frame specified in the request to the right of the contractor address. Progress notes and orders must be legible and signed. If the signature appears illegible, then you can create a signature page identifying the usual signature of the physician and attach it to the material sent. If the signature is missing, the physician can send an attestation stating that they actually saw the patient on the date of service in question. And when the service time of a particular code, like for therapy or mental health claims or infusions or critical care, the time must be documented on the chart, either in the format from X to Y or total time. When medications or lab tests are billed, there must be some documentation or order to show the medication was administered and the test was wanted or needed. Another reason why verifying benefits prior to the patient being seen is critical is that coordination of benefits. With Medicare, for example, a patient who's working or has a spouse who is working, they may have Medicare as a secondary payer. Patients with more than one insurance company, you don't need to verify the coverage is valid, but in order the plan believes that they are in and that they're aware there's other coverage. Ultimately, this really is the patient's responsibility. However, most patients are unaware that they need to do this, and this causes headaches for your billing staff and a delay in payment to your practice. Claim service lacks information that are needed for adjudication. Either the diagnosis code is not valid or needs to be carried out to the highest level, and CMS requires all Medicare practitioners use an ICD-9 code that has the highest degree of accuracy and completeness or the greatest specificity. That usually means providing an ICD-9 code carried to the 5th digit or as high as the diagnosis code is listed. For example, diagnosis code of 42.3 should be listed as 42.30. On March 23, 2010, President Obama signed into law the Patient Protection and Affordable Care Act, PPACA. This amended the time for filing Medicare fee-for-service claims. Under this new law, providers must file claims for services furnished on or after January 1, 2010 within 1 calendar year of the date of service. Effective just this year, January 1st, the Department of Health and Human Services and Division of Medicaid Long-Term Care, they'll make some changes to the regulations requiring the receipt of claims within 6 months of the date of service. Time limits are established based on state law, the contracts between the patient and the insurance company, and the contracts between the provider and the insurance company. So you need to know which has jurisdiction. Within state law, some states have time limits to submit claims and some do not. The time limit to submit a claim based on the patient contract. Some have a 90-day time limit, some have a year, and some have 2 years. I put in this picture on this screen to demonstrate a month-end process that's not paperless. The more robust your practice management software is for running reports, the far fewer headaches you'll have at month-end and have a better checks and balances in place with little room for human error. Now within this, talking about reimbursement, having some of these steps in place to be more proactive than reactive, following some of these benchmarking examples of things that you can do, hopefully some of these things can help your practice understand the processes of reimbursement and how you can better affect your bottom line. Now within this WebEx, if you wanted to go back and review the slides that are on here or log on to and review this presentation again, you log on to the MSO site and go down to Strategies of Success, and then I have them all listed. You just click on the training site that you want, and I have documents for some of these as well. And then if you want to have training, like the HIPAA training, if you want to navigate our website there, you have to click on the Training Center, and then you just have to click, it'll have HIPAA training right there. Once your staff members go through the HIPAA training, they have to have an 80% or higher pass rate in order to get a certificate. And all of those can be placed in there. You just have to click on Submit a Request if you don't have the HIPAA training or the OSHA training within your site. Just click on Submit a Request and we can put that into your module because everybody's access to the MSO site is different. It's built around your practice and your specific needs. So you just put in there, please send me my staff certificates and report, or if you're wanting to request a training, you can put it in there and click Send a Request. Once everybody in your practice has HIPAA and OSHA training and you've received your certificates, you can contact me and I'll show you how you can load them electronically into the contract tracker and the MSO website for your internal storage. I'm now opening this up to questions. Went through the reimbursement cycle basically and some things you can look for maybe to help you with your bottom line. But if you have any other questions, feel free to let me know. Thank you so much and have a good afternoon.